Welcome back to Your Health television program. I am Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so very pleased you could join us for this special edition of Your Health television program. The reason why this is a special edition is because this is October, of course, in the year 2012, and this is Breast Cancer Awareness Month. So I thought it would be appropriate that we spend the entire hour, 3 segments, devoted to the issue of breast cancer, breast reconstruction, breast cancer screening, etc. So I'm very pleased you could join us for this special edition of Your Health television program devoted to breast cancer. As you know, I'm a board-certified plastic surgeon. One of the most common requests that I see in my office is when I hear from the woman who has had a mastectomy or will have a mastectomy or lumpectomy, and she is interested in breast reconstruction or maintaining her symmetry, balance, and harmony. In other words, she's the kind of woman that is interested in her silhouette and does not want to be left with only one breast or absent both breasts, or with the result of a large lumpectomy, which might leave her out of balance or asymmetric. So let's review for a couple of moments. In this year, there are approximately 200,000 women in this country alone who will be diagnosed with breast cancer. In general, we can estimate that over the course of a lifetime, about 1 out of every 7 to 1 out of every 11 women will experience or be diagnosed with a breast cancer in her lifetime. That's really an incredible amount. It's really endemic. So again, in this year alone in the United States, approximately 200,000 women will be diagnosed with breast cancer. Now, not all of those women will be treated with a mastectomy or removal of a breast. However, a significant percentage of that 200,000 will be. Some women will get a lumpectomy, which is essentially removal of the lump containing the cancer. Other women will get a mastectomy. Some women will get a bilateral or double mastectomy. In addition, there are a huge number of women who in past years have gotten a mastectomy for breast cancer and who have not had breast reconstruction. So this introductory segment is devoted to those women who have had a mastectomy or who will have a mastectomy or lumpectomy and are interested in breast reconstruction. To begin, when I see women in my office who are interested in breast reconstruction, I tell them that in my mind, the way I conceive about this issue is that there are 4 main decisions, 4 main issues, 4 key topics to consider in breast reconstruction. To begin, number 1, the type of breast reconstruction to be considered. In this country, there are 3 common operations that we offer to women who are interested in breast reconstruction. Number 1, implant-based breast reconstruction. That's the use of tissue expanders and implants. Number 2, the latissimus flap. The latissimus is a muscle that extends from the shoulder down to the back that can be used to reconstruct the breast mound. The third most common operation that we offer in this country is the abdominal flap, often referred to as the TRAM flap, T-R-A-M, transverse rectus abdominis myocutaneous flap. There are many different ways that we transpose the TRAM flap, but they all take advantage of the abdominal tissue to reconstruct the breast mound. So, number 1, we need to choose the type of breast reconstruction. Number 2, we need to decide upon the timing of the breast reconstruction. There are 2 main categories of breast reconstruction regarding the timing. We pick from 2 main choices. Number 1, immediate breast reconstruction. What that means is at the time of the mastectomy, the breast reconstruction can begin. This can be placement of a tissue expander or even an implant in some rare cases. We can transpose the latissimus flap at the time of the mastectomy, or we could transpose the abdominal flap at the time of the mastectomy. The second most common option, or a second common option, is delayed breast reconstruction. What that means is that the mastectomy is done on one day. A woman may go on to have chemotherapy, she may go on to have radiation therapy, and then when her cancer is cured or controlled, we can then start the breast reconstruction process. That's called delayed breast reconstruction. For the sake of completeness and to fully cover the option, there's sort of a middle ground or a hybrid between immediate breast reconstruction and delayed breast reconstruction. That means at the time of the mastectomy, a tissue expander is placed. A tissue expander is a sort of a deflated water balloon that is slowly filled up. In either case, a tissue expander is placed at the time of the mastectomy. Within 1 or 2 weeks, a woman may get the final pathology report back to hear whether or not she needs radiation therapy, and then go on to either complete the tissue expander complete the tissue expander protocol or practice, or can be changed to a flap or autogenous tissue type of breast reconstruction. But in general, for all intention purposes, there is delayed reconstruction or there is immediate breast reconstruction. So again, to recap, the first important issue is the type of breast reconstruction. The second important issue is the timing of breast reconstruction. Now, number 3, we need to consider the contralateral or other breast. Why is that important? To consider the other breast is important for most women who have a mastectomy or lumpectomy, primarily because most women that I see in my office, they are interested in symmetry and balance and harmony. Most women would like to have approximately the same cup size when they go out to buy a breast. When they go out to buy a bra. Those women don't really want to have custom fitted clothing to accommodate different sized breasts, but they would like to have balance, symmetry, and harmony even after having a mastectomy or lumpectomy, even after having breast reconstruction. Hence, we will oftentimes offer to a woman contralateral breast surgery. There are 3 common options. We can increase the size of the non-operated breast. That's called augmentation, typically with an implant. We can reduce the size of the non-operated breast. That's called a breast reduction or reduction mammoplasty. Or we can lift the breast. That's called a mastopexy. And of course, there are certain hybrids where we may augment the breast, make it larger, and lift it. We can do some enlarging and lifting, etc. So again, the 3 common operations or procedures that we offer on the contralateral breast are number 1, augmentation, number 2, reduction, and number 3, lifting. All of those procedures have in mind, or the goal, the restoration of symmetry, balance, and harmony. So again, to recap, number 1, we choose the type of operation or breast reconstruction. Number 2, decide upon the timing. Number 3, choose whether or not we will operate on the contralateral or operate on the breast that is non-affected by the breast cancer. The 4th major issue to keep in mind when we counsel women about breast cancer and breast reconstruction is nipple areola reconstruction. Typically in my practice, I do that in a delayed fashion. There are local flaps where we move tissue around from the breast mound to recreate the nipple. The areola or areola is the tan part around a nipple. Typically, the women in my practice like the areola to have a real depth. So I like to do a skin graft for that portion of the procedure where I reconstruct the areola with a graft. That's when I take a little bit of skin from somewhere else, sometimes from the armpit, sometimes from the groin crease. If I do a latissimus or an abdominal tram flap, I can take the skin from where a woman already has a scar, so there's no additional scars. So hence, the nipple typically is made with a local flap as I move tissue around to recreate that nipple protuberance. And the areola, which is the tan part around the nipple, is typically made with a skin graft. Then a woman can have tattooing if she wants to more closely match the other side. So again, to recap, number 1, choose the type of breast reconstruction. Number 2, choose the timing of breast reconstruction, delayed or immediate. Number 3, consider contralateral breast surgery. Not all women will elect to have contralateral breast surgery or need it, but that's an important issue. And number 4, consider later nipple areola reconstruction. Now let's go back and fill in some of the gaps and provide you with some more information. Before going on, I do want to emphasize that the women who get the best results in breast reconstruction typically undergo touch-up procedures and revisions. It is certainly our goal to recreate the breast mound or reconstruct the breast mound as closely as can be physically, surgically, and humanly accomplished. However, the women who have the best match and best breast reconstruction, in my experience, have little or minor touch-up revisions. In a lot of those we can do in the office. Many of them we can do on an outpatient basis. So the first operation, where a woman has a mastectomy and breast reconstruction, or even if she has delayed breast reconstruction, if she had a mastectomy prior and then goes on to have delayed reconstruction, that's a fairly rigorous, involved procedure, typically involving a general anesthetic and sometimes an overnight stay. But a touch-up or revision procedure to obtain more symmetry, balance, and harmony, to go back and do some tailoring, sculpting, some shaping, that's oftentimes outpatient, can be done under sedation, sometimes a general anesthetic if a woman wants it. Minor revisions can be done in the office. So hence, please keep in mind that the women who have the best reconstruction or the best results from breast reconstruction typically have touch-up and revision operations. Now, let's go back and fill in some of the gaps and talk a little bit about specifics of breast reconstruction. I said the first major issue in breast reconstruction is to choose the type of breast reconstruction. Breast implants or implant-based reconstruction, number 2, latissimus flaps, and number 3, abdominal flaps. So number 1, implant-based reconstruction. That means a device is used, such as a tissue expander, which is later converted to a saline implant or silicone implant. That provides the volume and some shaping to the absent breast. What's a tissue expander? A tissue expander is essentially a flat water balloon that can be inserted under the pectoralis muscle, the main muscle of the anterior portion of the chest wall, or it can be inserted just under the skin and subcutaneous tissues in a delayed breast reconstruction. So a tissue expander essentially is a flat water balloon that we insert underneath the soft tissue in the operating room with an anesthetic. Then we sew up the incision that we use to put in the flat water balloon or the tissue expander, and we let everything heal. So then in the office, typically about 2 weeks later, through a valve, through a little port that can be located with a magnet because there's a metal backing, we have something called a magnifinder, which is similar to a stud finder that you'll oftentimes see carpenters use. It's a little mechanical device with a pointer and a little mobile arrow with a magnet that will point to and help us find where the valve is, because it's metal backed, and we can do that right through the skin. So in the office, under sterile conditions, once we locate the valve, we can insert a needle attached to a sterile syringe containing sterile saline or normal saline. That's salt water with the same concentration that we find in our serum, and that can be injected through the valve that's underneath the skin, and it just flows into the tissue expander. That can be done about every week or every 2 weeks for a few weeks, and little by little the overlying soft tissues are stretched out to get to the size that we want to be to match the other or contralateral side. That's a tissue expander, tissue expansion process. Typically, in my practice, I like to overinflate or stretch the skin and overlying soft tissue a little bit more than is needed, because when we go back to the operating room, remove the tissue expander and convert to a implant, such as silicone or saline implant, breast implant, having a little bit of extra skin, a little bit of extra stretching will give us a more natural, mature breast that will typically match the other or contralateral side more closely, more realistically. So that's the tissue expander process. In summary, a device-based breast reconstruction is relatively simple surgery. It doesn't involve scars anywhere else. We don't have to harvest or take tissue from the back or the abdomen. It's just limited to the surgical site. However, the downside is that it's a foreign material. So some women don't tolerate that foreign material or the breast implant very well. There's something called capsular contracture, where the normal scar tissue formed by the body sort of gets thick and starts to contract and be tight around the breast implant. That's called capsular contracture. It's not really that the body is rejecting the breast implant, but it's just that the normal scar tissue starts to squeeze and contract, making the breast implant feel harder. That can happen in cosmetic or aesthetic breast augmentation as well. But that's a summary of the first type of breast reconstruction we offer. That's implant-based or device-based breast reconstruction. The second most common operation that we offer in this country is the latissimus flap. Again, the latissimus is the tissue, the latissimus is the muscle that runs from the back of the shoulder down towards the lower part of the spine. It's a fan-shaped muscle, a very broad, strong muscle. The weightlifters refer to it as the lats. The women weightlifters and the men weightlifters call that the lat. So that muscle with overlying skin and a little bit of fat, that can be transposed essentially through the armpit or around the side of the thorax to the site where the breast is absent or has been removed, and we can use that tissue to rebuild the breast mound. That's the latissimus flap. If a woman has a relatively small to medium-sized breast and has a relatively robust donor site, in other words, a relatively robust, or if she has a stocky appearance, that back tissue or latissimus tissue can in and of itself reconstruct a breast mound. For a woman who needs or wants a little larger breast reconstruction, we can oftentimes put an implant in underneath the latissimus flap. So again, that's sort of a hybrid using both an implant and the latissimus flap. The advantage is it's a hardy flap. We can get good vascularized living tissue that's hardy. The downside is that, of course, it leaves a scar on the back, and for a larger breast, we also need to use an implant. Now, the third most common type of breast reconstruction we offer is the abdominal flap. There are many ways that we can transpose the abdominal tissue to the breast area and chest area to reconstruct a breast mound. We use the rectus muscle, which is one of the paired muscles running up and down or vertically in the abdomen. We can use that muscle as a type of vascular leash. That's called a pedicled abdominal flap, or the TRAM flap, as I said, transverse rectus abdominis myocutaneous flap. So essentially, we take the lower abdominal tissue, the skin and the fat, and it's transposed to the area where the breast is missing. Think about a tummy tuck for a moment. In a tummy tuck or abdominoplasty operation, we make a very long incision, actually a couple of incisions, to take an ellipse shape of tissue, almost like a, well, not quite a crescent, but a type of oval shape, or a incision where that's curvilinear or curved up on top, and then we make one underneath to take a significant amount of the skin and fat in a tummy tuck or abdominoplasty. When a tummy tuck or abdominoplasty, that tissue would be discarded. In an abdominal flap breast reconstruction, we don't discard that tissue, but we leave it attached to the rectus muscle and then either reconnect it with a microscope to the chest wall and around the pectoralis muscle to rebuild the breast mound, or we can leave it attached to the muscle and tunnel underneath the skin to that area, leaving it attached to the muscle, the pedicle. That provides the vascular leash for the breast reconstruction. The abdomen, of course, is closed up. It leaves a permanent visible scar, a long permanent visible scar, very similar to a tummy tuck scar or incision that's quite low. So a woman can tend to hide that with a swimsuit or bathing suit bikini. Certainly it can be made to go underneath the line of where her pants would be buckled or buttoned. So that's an introduction to an abdominal flap type of breast reconstruction. The advantage is it brings up a good amount, quite a bit amount of robust, vascularized, healthy tissue to reconstruct the breast mound with so-called natural tissue. The downside, it's a larger operation. It's a more complex operation. If we do microsurgery, we have to coordinate a team. We have to expose and prepare blood vessels that can be the recipient vessels, whether they're the internal mammary vessels or the thoracodorsal vessels or the thoracoacromial vessels. We have to prepare those vessels that will then be anastomosed or hooked up to the artery and the vein in that lower abdominal tissue that was transposed. So the key issue here is blood supply. There's a phrase we use in plastic surgery, beauty versus blood supply. Any tissue we transpose, we have to restore or maintain the blood supply as we shape and mold and tailor. So that's an introduction to the category number one, the main types of breast reconstruction. Perhaps now it's a good time for us to take a little break, and then we'll continue with our discussion about breast cancer and breast reconstruction, since this is October Breast Cancer Awareness Month. What I'd like to do, however, is take a very brief moment to mention our DVD. I'd like to thank the wonderful Dina Ruiz Eastwood for being the host of this DVD. The name of this DVD is Breast Reconstruction, Know Your Options, A Guide for the Woman with Breast Cancer. During this month, October, Breast Cancer Awareness Month, this is absolutely free to women in the Tri-County area by calling my office or emailing. I'm Dr. David Morwood. The number is 831-646-8661. That's 831-646-8661, or go to my website, drmorwood.com. That's D-R-M-R-O-W-O-O-D, drmorwood.com, or go to the website, breastreconstructiondvd.com, breastreconstructiondvd.com, and look into having a courtesy copy of this DVD teaching you all about the options for breast reconstruction, once again hosted by Dina Ruiz Eastwood. I think that's a good point for us to take a brief pause for a good cause. Once again, I'm Dr. David Morwood. This is Your Health television program. I'm a board-certified plastic surgeon, and we're going to come right back after a very brief pause for a very good cause. Thanks so much for being here. We'll be right back.